Hello, can anyone hear me?
I am listening you.
Okay. So, I just wanted to know about my presentation. Means it will come automatically or what?
Dr. Sajid.
Try to share your screen. I am stopping my screen share. Try to share your
Okay.
PPT now.
Uh-huh. Okay.
Just share your screen, ma'am. You are co-host now. You can share anytime.
Uh, Means you want me to share or you have my presentation?
No, ma'am. You share it at your end. Try to share, ma'am. It will be
Uh,
there from
that,
your end.
that's what I'm telling you that how I don't know how to share it. This is what I was talking about. Means do I need to share my? I have already sent my presentation to Dr. Lalit sir. So you handle my presentation and I will just speak.
Okay, that can be possible. Sajid,
Yes, ma'am. Just I will share the PPT and ma'am will say next and previous, and I will just move the PPT up and down.
Yeah. That can be done.
Yes, ma'am.
Can you show my presentation?
Yes.
Means the
I am just showing it, ma'am.
hmm. ये मेरा प्रेजेंटेशन तो अभी किसी को ऊपर 5 बजे तक नहीं आना ठीक है जब तक हम कंप्लीट नहीं करेंगे
Okay, ma'am. Can you see your slides? Nupur, ma'am, can you see your slides?
ठीक है तो 2-3 मिनट में साजिद बोलेगा. Okay, Sajid. Now
Yes,
we
sir.
can start.
Okay, sir. We are just starting, sir.
We can now start with the Dr. Hariyar Dixit sir.
Okay, sir.
So
recording in progress
ये बोला है तो पर यहाँ से लाइट का प्रॉब्लम है मेरा इस तरफ से शुरू ये बंद हो गया नो विजिबल तो विजिबल है
Yes.
नहीं और हमके तो हो रहा है खराब सब फोन पे की कार है mute पे
You are not unmute.
अच्छा हाँ स्टार्ट कर सकते हैं. Welcome to this session. Good evening, everyone. Welcome to the update in pharmacotherapy of schizophrenia, a webinar organized by Academic Society of Pharmacologists of IGMS in collaboration with Department of Psychiatry, AIMS, and PMCH, and the Department of Pharmacology, IGMS Patna. Schizophrenia remains one of the most challenging conditions in psychiatry, which is often marked by thinking and social withdrawal. However, our understanding of neurology, neurobiology deepens, so does the approach of our treatment. Today, we would bridge the gap between basic pharmacology and clinical practice, focusing on how better we can manage this condition through targeted innovative therapies. It is my pleasure to begin this program. Now, I may invite Professor Dr. Harihar Dikshit Sir, the President of ASPI IGMS and the Principal of NSMCH Beta, Emeritus at IGMS Department of Pharmacology, Patna, to deliver the welcome address. We are honored to have such an accomplished leader and a pioneer in the medical education with us online to share his valuable insights. Please join me virtually in giving a warm welcome to Professor Dr. Harihar Dikshit Sir. Please mute.
Yes, sir, you are
Yeah.
muted.
Now-
Now you're audible.
Now you have given me the opportunity. Thank you, Sajid Bhavna. It's my honor that you have invited me to deliver welcome address. So I think Professor Vikas Mehdi is there. He's a professor of pharmacology, PGI Chandigarh. He's chairman IUFAR and also the founder of experimental pharmacology lab and neurobehavioral lab at PGI Chandigarh. Professor Nupur Niharika, I think I've seen her. Professor Pankaj Kumar, professor and head psychiatry department, AIMS Patna. I have not seen Dr. Rajesh, Professor Rajesh Kumar, Dean Research, IGMS, Professor Lalit Mohan, who is instrumental in organizing this webinar, and my fellow colleagues, other speakers, and delegates. Good evening to all of you. Am I audible? Am I audible? Hello? Am I audible?
Yes, sir, you're audible, sir.
Yeah.
You're audible clearly.
Good evening to everyone. As the founder president of the Academic Society of Pharmacologists of IGMS, it gives me immense pleasure to welcome you all in today's webinar on updates in pharmacotherapy of schizophrenia. We are indeed honored by the presence of Professor Vikas Mehdi, Professor Nupur Niharika, Professor Pankaj Kumar, Professor Rajesh Kumar, Professor Lalit Mohan. So, for your willingness to share your knowledge with experience to all of us. I must appreciate the efforts of all the office bearers of SPIGMS for organizing this webinar and making SPIGMS more visible on the academic platform and more vibrant. It was founded with the vision of promoting continuous learning and encouraging interdepartmental dialogues. So, you people are fulfilling this, and I think going to achieve the vision of SPIGMS. Schizophrenia, today's is the topic schizophrenia, updates on in pharmacotherapy of schizophrenia. Schizophrenia remains one of the most challenging psychiatric disorders, not only because of its complex neurobiology, but also due to profound impact it has on patients, families, and the society at large. While we have made significant strides in understanding its pathophysiology, the journey towards more effective, safer, patient friendly treatments continues. The aim of now the prescriber or physician should be to treat acute symptoms, or you can say control positive symptoms, and also to prevent relapses of the symptoms, to enhance quality of life, and to reduce, as a pharmacologist, I must say, to reduce adverse drug reaction to drugs. So today's session, I think, will be dedicated towards rational pharmacotherapy of schizophrenia with the precision approach. So today's session is dedicated to exploring the latest advancement in the pharmacotherapy, from structure activity, relationship, selection of antipsychotic drugs, preclinical and clinical aspect, to personalized medicine approaches for treatment of schizophrenia. We are having Professor Vikas Mehdi, who is a pioneer of neurobehavioral studies, and he is already, as I said earlier, founder of neurobehavioral lab at PGI Chandigarh. Also, Professor Pankaj Kumar, Professor Rajesh Kumar, and Professor Nupur Niharika from PMCH, and also the pharmacologist ललित मोहन. एक संगम है जहाँ की इस संगम त्रिवेणी से, जहाँ फार्माकोलॉजिस्ट भी अवेलेबल हैं और क्लिनिशियंस भी हैं. हम सबों को इससे लाभ मिलेगा. आई थिंक आई मस्ट say I would like to thank our distinguished speakers for participating in the webinar, and I will share their and will share their expertise and our discussions, learn and collaborate. With that, I once again welcome you all from my heart for an engaging and insightful discussion. Thank you very much to all the speakers, participants, and organizers. Thank you. Thank you, Sajid.
Yes, sir. Thank you so much, sir, for your warm welcoming words. Next, we move on to the science behind our treatment. But before that, I request all our delegates to please put their mics on mute, keep their cameras off, and kindly ask any questions in the in the drop box.
Yes, yes, आ रहे हैं.
It is an honor to introduce our today's guest, Professor Dr. Lalit Mohan Sir, Professor and Head, Department of Pharmacology, IGMS, Patna. He is a prolific researcher with over 80 publications in distinguished journals. He has also served as a lead investigator for projects funded by ICMR and DST. He serves as a vice president of ASPI IGMS, and he has extensive contributions in pharmacotherapy and meta-analysis methodology. Now, please join me in welcoming Professor Dr. Lalit Mohan sir, who will be speaking on structure-activity relationship and mechanistic implications of antipsychotic medications.
Okay,
Over
thank
to
you.
you, sir.
Thank you, Dr. Vamna. I am audible to all.
Yes, sir.
Okay. So first of all, I am going to thanks to my uh, previous director, Dr. N.R. Biswas, and previous director, Dr. N.R. Biswas. That time we have opened the course like DM Clinical Pharmacology, PhD, MD Pharmacology, or very crucial role played by our that time Dean is also our ex-HOD, Dr. Hariyat Dixit sir. Now presently he is a principal of NMCS Vista. So in this eastern region, we are proud to say we are running all the courses related to the pharmacology. So even many of the things we are running under the guidance of IGM's director, Dr. Professor Binde Kumar sir, like we have the inaugurated molecular pharmacology lab. So we are moving towards the pharmacogenomics and others. We are going to organize Kasi Pharmacon at Kasi. So we welcome to all of the delegates to join us at Kasi Pharmacon. So in the concern to my topic is today for a structure active, or not only that, we have today, the sir, as I told before, it is a sangam of the clinician and pharmacologist. I am very happy today we have the work collaborated. Otherwise, pharmacologists always say, okay, we have no correlation with the clinician and that like that. So you have to try with us, try like that. So always you can give, always you have, always you can work like, collaborate like the clinician. So in this regard, we have the today eminent pharmacologist, Dr. Professor Vikas Mehdi. So Dr. Professor Vikas Mehdi is a neurobehavioral science lab and eminent pharmacologist of India. We have 3 HOD from Patna as a psychiatrist, one from AIMS Patna, Dr. Pankaj Kumar. Another is always helped me, Professor Dr. Rajesh Kumar, HOD Psychiatry, as well as Dean Research, IGMS Patna, Professor Dr. Nupur Niharika, HOD PMC Patna. So all the eminent psychiatrists of Patna is present in today's webinar. I am thankful to them. So in concern to my topic, a structure activity relationship and mechanistic implication of antipsychotic medicine. I am very basic things I am going to tell today only. So in this regard, so for my topic, a specific learning objective, he described the role of a structure activity relationship of antipsychotic drugs influence their therapeutic efficacy and adverse effect profile in the management of schizophrenia. As sir told before, we have to worry about the adverse effect also. Efficacy, okay. Efficacy is definitely a problem with the schizophrenic patient because schizophrenia is a mysterious disorder. So as a relation to the drugs, we have the considered schizophrenia with the dominant of the positive symptoms and negative symptoms. Positive symptoms like delusion, hallucination, agitation, disorganized way. So typical antipsychotic work moreover better in the positive symptoms, whereas the negative symptom like lack of emotion, anhedonia, lack of motivation, decreased attention span and memory, difficulty in making the decision. So this negative symptom is better covered by atypical antipsychotics. So we have the four dopamine pathway. One is a nigrostriatal dopamine pathway, another is a mesolimbic dopamine pathway, another is a mesocortical dopamine pathway, another is a tuberoinfundibular dopamine pathway. So nigrostriatal dopamine pathway is a mainly concerned with the blockade of dopamine receptor to basis for extrapyramidal symptoms. Whereas a mesolimbic pathway is a ventral tegmental area to nucleus accumbens, that is a raised level of dopamine neurotransmitter is responsible for the positive symptoms of schizophrenia. Mesocortical dopamine pathway, that is extended from ventral tegmental area to axon of limbic cortex. Here is a decreased dopaminergic activity lead to the, or you can say, responsible for the negative symptoms of schizophrenia. Tuberoinfundibular pathway, that is a extension of hypothalamus to anterior pituitary gland. There is a dopaminergic inhibitors or dopaminergic antagonist releases the prolactin release, so that is responsible for hyperprolactinemia. So there are two hypotheses. One hypothesis is dopamine hypothesis, another is a serotonin hypothesis for or drugs working on this against that. So drugs acting on the dopamine, they're called as a typical antipsychotic. Drugs working on the serotonin and dopamine is called as a atypical antipsychotics. So neuroleptics or antipsychotics. Neuroleptic means nerve seizing drugs, or neuroleptic also known as antipsychotic. So D2 receptor antagonist is a tip with substantial risk of extrapyramidal symptoms. So basically, previous one drugs are, that is a D2 receptor antagonist with the substantial risk, or we can say neuroleptics or antipsychotic. Previously, what we are using for those drugs which acts on D2 receptor antagonist with substantial risk of extrapyramidal symptoms. So D2 receptor antagonist is the substantial risk of extrapyramidal symptoms. So there are two classes of neuroleptic drugs: typical antipsychotics or typical neuroleptics, atypical antipsychotic, atypical neuroleptic, that is also called as serotonin dopamine antagonist. First antipsychotic drug, chlorpromazine, in 1952 discovered as a serendipitously or serendipitously. This chlorpromazine used as antihistaminic and showed the effect against schizophrenic patient. So regarding the typical antipsychotic, or that is a most of the drugs belong to phenothiazine skeleton. So what is a phenothiazine skeleton? That is a phenothiazine skeleton is a two benzene ring attached with the nitrogen and sulfur atom. So a structure of phenothiazine based on common skeleton with two variable functional group. This has two functional group, that is R1 and R2. That is R1 and R2. So chlorpromazine, that is a aliphatic side chain, that is a structurally substituted aminopropyl at R1, and chloride is R2, and compound is a chlorpromazine. That is a prototype drugs for antipsychotic. That is a prototype drugs belongs to antipsychotic. Next is a thyroidine. R2, here is R2 is replaced by, piperidine side chain in thyroidine. This group has lower incidence of extrapyramidal side effect. Next is a piperidine substituted phenothiazine at R1. This is a piperidine side chain substituted at R1. The compound is a full phenazine. It is also available as a full phenazine depot preparation like full phenazine deconate. This full phenazine or piperazine site substituted phenothiazine is more potent than aliphatic substituted phenothiazine, and it is a more to produce extrapyramidal side effect. Next is a thioxanthine substituted. Thioxanthine is here is instead of nitrogen, here is substitution of here these two benzene ring is not attached with the nitrogen and sulfur. Instead of nitrogen, here is carbon and this thiogen skeleton. And this is replaced by this thiogen skeleton and carbon of the phenothiazine nitrogen. Instead of nitrogen, carbon is in phenothiazine skeleton. Compound is a full flupenthioxole. That is a highly potent typical antipsychotic associated with the extrapyramidal side effect. Another is a butyrophenone. Butyrophenones are structurally distinct from phenothiazine and thioxanthines, and there is increased risk of extrapyramidal side effect. It is a potent compound. So classification of typical antipsychotic: aliphatic side chain, chlorpromazine, triflupromazine, piperidine side chain, thyroidogene, piperidine side chain, trifluperazine, fluphenazine. So here we are giving the stars. So like 1 star, low potency with high anticholinergic effect. Means when those compounds have low potency, generally high anticholinergic effect, means less chance of produce extrapyramidal side effect. Double one is a piperidine side chain, is a thyroidogene. There is a lower incidence of extrapyramidal side effect, but compared to the piperidine side chain, it is a compared to the piperidine side chain. Third one is a high potency. That is a piperidine side chain, the high potency with relatively big anticholinergic effect. Big anticholinergic effect and greater risk of extrapyramidal side effect. Generally, generally those have the dopamine antagonist that can lead to cholinergic overactivity. So those have anticholinergic activity more, there is a less chance of extrapyramidal side effect. And also they can produce less sedation and hypotension. Thioxanthine derivative, piperidine side chain, fluphenazole. I told you earlier also there's a high potent and typical antipsychotic associated with the extrapyramidal side effect. Butyrophenone, again, it is a more potent one and there is a more chance of extrapyramidal side effect. One is a penfluoroidol, that is a potent neuroleptic with prolonged action. Another is a doroperidol, that is a highly sedative neuroleptic. It is used as a general anesthesia and psychiatric emergency. So, a structure activity of phenothiazine and carbon 2 substituent electron withdrawing group increases potency. If it is in C2, there is a more increase in potency. So there is a like C2, C3. If it is a present on electron withdrawing group present on C2, there is increase in potency. So there is increase in potency. There is a more chance of extrapyramidal side effect. Potency order here also we can in that electron withdrawal group in case like the fluorocarbon, chloride, and hydrogen. So fluorocarbon with the more electron withdrawal group. Lipophilicity with the electron withdrawal group is increases with lipophilicity. Electron withdrawal group is increases with lipophilicity. So like that, fluorocarbon has more compound with the fluorocarbon group have more lipophilicity. So newer antipsychotic drug, that is most of that drug is a Gen G, or later on it has also come like alpha. So this group of drug have moreover larger aromatic group benzene rings. So there is they have tendency to decrease the attachment with the dopamine receptor. Otherwise, so clearly distinct function like is not so clearly known in the terms of the structure activity. But moreover, benzene ring or aromatic group, here there is a detachment to the not attachment, not detachment with the dopamine receptors like that. So here there are moreover attachment with the serotonin receptor. So the atypical shift beyond the dopamine receptor antagonism. So lower D2 occupancy or fast dissociation for D2 receptor with these atypical antipsychotics. Potent serotonin 5-HT2 receptor antagonism improves the negative symptoms and reduces the extrapyramidal symptom. But these atypical antipsychotics, moreover interaction with the receptor like H1, M1, alpha 1, drive side effects with this receptor profile like H1, M1, and alpha 1. So here I told before also a structure activity relationship is not so predictable, but there are like the moreover the aromatic groups, there is a somehow detachment with the D2 occupancy. So structure activity of atypical antipsychotic and metabolic side effect. Significant problem with this atypical antipsychotic is a weight gain, diabetes, and dyslipidemia. Primary driver a high affinity to histamine receptor. A structural correlation. High affinity weight gain moreover common with the clozapine or olanzapine. Dibenzodiazepine, thion-benzodiazepine with the central nitrogen ring. Low H1 affinity, a low weight gain with the aripiprazole, ziprasidone, loxapine. Here is a dibenzoxazepine with the central oxygen atom. So just a little bit about the chlorpromazine is a prototype drug. It is a D2 receptor blockade that has relieved the psychosis, extrapyramidal side effect, antimimetic, and hyperprolactinemia. M1 receptor blockade lead to anticholinergic effect. Alpha 1 receptor blockade lead to hypotension, dizziness. H1 receptor blockade lead to the weight gain and drowsiness. The adrenergic blocking activity graded as more with the chlorpromazine, so it will be more potent, have less alpha blocking property. So chlorpromazine is more chances to produce hypotension. Low potent have high anticholinergic activity, like chlorpromazine have comparatively less chance to produce extrapyramidal side effect, but more have a chance to produce postural hypotension. So like the extrapyramidal side effect or neurological side effect, blockade of, I told before, blockade of D2 receptor in basal ganglia or nucleostriatal pathway is responsible for extrapyramidal side effect. Anticholinergic agent decreases the extrapyramidal side effect. So it is also previously we are using along with the combination of anticholinergic like the benzoxazole and antipsychotic together, but these anticholinergic drugs are responsible for the long-term use is a dementia. So what are extrapyramidal side effects? Increased cholinergic activity in the basal ganglia lead to the extrapyramidal side effect, acute dystonia, ectasia, Parkinsonism, neuroleptic malignant syndrome, and tardive dyskinesia. So this acute dystonia generally occurs in time in 1 to 5 days. Here is a somehow central acting anticholinergic drug is useful in this treatment. Even not only antipsychotic, metoclopramide in children also produces acute dystonia. Ectasia here is an acute dystonia, is a spasm of the muscle, tongue, face, and neck, facial grimacing. So ectasia is a motor restlessness. It is generally occur after the 5 days or within 60 days. So here is a treatment is a beta blocker or diazepam like drug clonazepam. Parkinsonism is a somehow long-term process to development with the Parkinsonism. So here is a dose reduction, change the medication, or anti-Parkinson agents. Neuroleptic malignant syndrome. Here is symptoms like extreme rigidity, fever, unstable BP, myoglobinemia, others. Here is a treatment is bromocriptine and dendroline. Okay, so tardive dyskinesia is a restless type situation. Orofacial dyskinesia rarely widespread, so it is months to year to develop. treatment is a very difficult or unsatisfactory. Atypical antipsychotic agents with the substantial lower risk of extrapyramidal side effect and serotonin dopamine antagonist. These are belong to serotonin dopamine antagonist. Drugs are clozapine, olanzapine, risperidone, aripiprazole, quetiapine, cetinidol, ziprisidone. Here you can see the chart will can demonstrate the attachment with the D2/5:2 ratio. So you can see those have aliphatic side chain in phenothiazine like chlorpheniramine, that is attachment with more over with the D2 receptor compared to the 5:2 receptor. And in like the atypical antipsychotic, this attachment with the D2 receptor is low, and moreover attachment with the 5-HT receptors. So this table shows the relative potency. So chlorpromazine is less potent. So the dose is like 300 to 1500 milligram. So it is a less chance of extrapyramidal side effect, but can be more chance of postural hypotension. Haloperidol is a more potent. So there is a more over extrapyramidal side effect. Full thiazole is a more potent. So there is a more extrapyramidal side effect. Atypical, here is among the atypical antipsychotic, risperidone is a more potent one. So among the atypical antipsychotic, risperidone is a more of a chance to produce extrapyramidal side effect among the atypical antipsychotic. So weight gain. So like haloperidol is very mild. Weight gain is more over common with the olanzapine. Everyone knows about that. So olanzapine weight gain is reduced by concomitant use of metformin in some patients. Our recent drug our trial was going on in the semidorphan, mu receptor antagonist and olanzapine. FDC recently approved by, and this fixed dose combination recently approved by FDA USA. So this semidorphan is a mu receptor antagonist. They combined with olanzapine to reduce the weight gain. QTC prolongation is mainly with the quetiapine. On others, they are given as in charts. Hyperprolactinemia is moreover common with those have the moreover dopamine receptor blockade, like haloperidol, persistent elevation, and like that only. Okay. So conclusion. Continued structure activity studies aim to dissociate therapeutic effect from metabolic side effect. So we have to like structure activities give some idea about the therapeutic activity effects and metabolic side effect for the next generation of antipsychotic and will be helpful to preparing the standard treatment of guideline. So this structure activity give the ideas about to prepare the standard treatment of guideline. Thank you. Thank you. Okay.
Thank you, sir, for those valuable insights, and your overview has provided us a clear foundation of understanding these essential drugs and their use in the treatments. Now, let's move forward, and it is my absolute pleasure to introduce Professor Dr. Niharika Nupur, Head of the Department of Psychiatry, PMCH Patna. She will be sharing her expertise on the selection of antipsychotic drugs for the treatment of schizophrenia. She is serving as the president of Patliputra Psychiatric Society, a zonal representative of Bihar State, and an executive committee member of the IPS East Zone. With over 20 publications in various journals, she is a distinguished contributor to this field. Let us welcome ma'am.
Nupur ma'am, are you audible?
प्रोबेबली वो एक बार फोन कर लो.
Okay, sir. Nupur ma'am, you can unmute yourself. I have made you co-host.
Questions के लिए पूछ लो.
नहीं नहीं, आप अपने को म्यूट से हटाइए ना वहां से को.
Nupur ma'am, you can unmute. Unmute.
पूछ लो question.
Am I audible?
Yes, ma'am, you are audible.
Okay, okay.
Welcome, ma'am.
Yeah. So thank you. I'm very sorry for the inconvenience. So first of all, I would like to Professor. Very good evening to Professor Dikshit sir, Lalit sir, Pankaj sir, Rajesh sir, Dr. Vikas sir, and all audience whosoever is present over here. So without delaying, I just start my presentation. Next, please move my next slide. So Dr. Yeah, yes. So basically, we are discussing today about schizophrenia, and we all know that schizophrenia is a chronic mental illness which affects our ability to think, perceive, perception, and behavior. So, what is the global incidence, global prevalence? It is about 1%, and about 10% of schizophrenic patient they commit suicide. As we all know that clinical feature is divided in positive symptom, negative symptom, and cognitive symptoms. Positive symptoms in form of hallucination, delusion. Negative symptoms in form of evolution, alogia, anhedonia. Then cognitive symptoms in form of impaired attention, memory, and executive dysfunction. And because of that, there is significant impairment in social and occupational functioning. Next slide, please. Next slide, please, Dr. Adil. Yes. So, what is the current treatment challenges? So, because we are discussing today what about the selection of antipsychotic treatment, antipsychotic drug for the treatment of schizophrenia. So, we need to know what are the current challenges. Previous slide. So, about 50 to 70 percent patient they respond to first drug trial and in when they tried for next drug, that is second trial of drug, the response rate is 20%, and it is again very disheartening that about 30% of schizophrenic patients they are treatment resistant. And one other main problem is problem of non-adherence, that is within 2 years about 75% of patients they just discontinue treatment, and they then there is relapse. So these are the treatment challenges. So now, as Lalit sir has already, next slide please. Next slide please, Dr. Adil. Next slide, please. So, Dr. Lalit has already pointed out that there is typical and atypical drug, and what are the mechanism of action and side effects. So, here I would like to focus more on the clinical part. So we know that according to dopamine hypothesis, it is the D2 receptor which is responsible for the positive symptom in form of hallucination and delusion. So we need to, in order to reduce positive symptom, we need to block the D2 receptor. And so the first generation drugs such as chlorpromazine, trifluperazine, flufenazine, then haloperidol, these are the drugs which which mainly acts on D2 receptor, and they are basically D2 antagonists. So we have another drug, another group of drug, that is second generation antipsychotic, and that acts by blocking not only on by blocking D2 receptor but also 5-HT2A receptor. So it blocks, we need to understand, so it has dual receptor antagonist, that is 5D2 and 5-HT2A. There is third generation drug as well. So it is basically partial agonist of D2 receptor and 5-HT1A. So here receptor is 5-HT1A receptor, and this is partial agonist. So we will understand later on what is the how it is beneficial. So every drug has got its own effects and side effect, and so we need to choose which according to various parameters, patient profile, cost, efficacy, which I will be dealing later on. Next slide, please. Yes, so in this slide we can see that this D2 receptor, what it does, that it blocks the D2 receptor, and because of that it reduces positive symptom, but at the same time it also causes, it blocks the pathways which is where it is already less, such as in mesocortical pathway. So negative symptom will increase, affective symptom will get affected, and there will be drug induced Parkinsonism, and there will be also prolactin, there will be galactoria, because it blocks the inhibitory effect of dopamine. So that way it has got side effect in terms of EPS, as my previous speaker was telling about this. Next slide, please. So first generation drug has got EPS and drug-induced Parkinson's and galactoria, amenorrhea. So what is the first generation versus, we need to understand what is the difference between first generation antipsychotic and second generation antipsychotic. This I am telling you because we need to understand that what are the various options we have among antipsychotic. So first generation, second generation, and third generation. So first generation, as I already told you, it is chlorpromazine, haloperidol, trifluperazine, flufenazine, and others as well. So in second generation antipsychotic and third generation antipsychotic. So first come to second generation antipsychotic. So next slide, please. For second generation antipsychotic, we have pines, we have dons and rons. So among pines, we have clozapine. This is the prototype drug in second generation generation antipsychotic, and basically it is apart from clozapine, we have olanzapine, quetiapine, acinapine, and zotipine. So it blocks not only D2 receptor, but it also blocks 5-HT2A. So and by blocking 5-HT2A in the region that is prefrontal dorsolateral dorsolateral prefrontal cortex, it increases the level of dopamine where it is hypothesized to be reduced. So in that way it increases, it has beneficial effect in negative symptoms, cognitive symptoms. So and this is the difference between the first generation antipsychotic and second generation antipsychotic. So we have talked about pines. Now come to risperidone, don and ron groups. So next slide, please. In don group, we have risperidone, then paliperidone, then iloperidone, then loracidone, and we have another latest drug which has come up recently, that is lumateperone. So these dons and rons is basically, again, they act mainly on D2 receptor as well as 5-HT2A receptor. So what is the difference between don and then pines? So it is the difference between basically the how potent they act on that on particular receptor. So in this diagram we can see that this red line is the D2 receptor binding capacity or binding, how potent it binds, and the left and right, it shows that the 5-HT2A, if it is more potent, then it is on right side, and if it is less potent, then it is on left side. Next slide, please. Next slide, Dr. Shazid. Next slide. So, SGA, what is the key safety consideration? As I said, that first generation has got, it is very potent drug, but it has got side effect in terms of EPS, akathisia, acute dystonia, drug-induced Parkinsonism. So, but at the same time, we have second generation antipsychotic, and they have got their side, because they act on various other receptor, so it causes motor impairment in like EPS. It does cause EPS, such as risperidone, paliperidone. Then it also increases prolactin activity. Then drugs such as olanzapine, quetiapine, it increases weight. And then metabolic syndrome, which is the main problem with second generation antipsychotic. It mainly olanzapine, risperidone. It is responsible for metabolic disturbances. Then we have cardiovascular risk factor. Again, the second generation antipsychotic, they tend to cause metabolic syndrome. So in one hand, we have first generation antipsychotic with EPS, and in second hand, we have as, drug with side effect as a metabolic disorder, metabolic syndrome, that is obesity, hypertension, high blood pressure. So both are problematic. So next slide, please. Both are problems. So now, what is the third generation? Here, the role of this third generation, that is partial agonist at D2 receptor and partial agonist at 5-HT1A receptor. So we have aripiprazole, brexpiprazole, and cariprazine. So this aripiprazole and brexpiprazole is supposed to have very good antipsychotic, in terms that it is as potent as second generation drug, but it has got very low side effect as compared to SGA in terms of metabolic syndrome, and also in term if it is compared with first generation, it has got less or negligible EPS. So this is the third generation, and it is supposed to be a very good antipsychotic drug. So let us see further. Next slide, please. So next slide, I have already discussed this. So how this partial agonist benefit differs, because it is partial agonist on D2 and D3 receptor, it is there is improvement in positive as well as negative symptom, depressive symptom, and it has also got pro-cognitive effect. It does not deteriorate cognition, but rather it improves cognition. The next, because its action on 5-HT1A receptor as partial agonist, there is improvement in negative symptom, and as well as there is improvement in depressive symptom. So, and because its action on 5-HTA2A antagonist, it has got lower risk of EPS. At the same time, it has activity on alpha 1B receptor, and because of this, again, it has got lower risk of EPS and akathisia. Next slide, please. So partial agonist, who could benefit because of this partial agonist, that is aripiprazole, brexpiprazole, and cariprazine. The person who are obese or overweight patient having acute psychosis with fear of side effect, I won't take medicine because there will be I will be obese and I may develop metabolic syndrome, or I might develop EPS. So those patients can be prescribed partial agonist. Then women with diabetes and overweight, then man with gynecomastia or with other endocrinal disorder. So these patients can be benefited with third generation antipsychotic. Next slide, please. So these are all about what type of antipsychotic right now we have in our pocket. So we have first generation, second generation, and third generation. So how to choose? My topic was how to select antipsychotic drug for the treatment of schizophrenia. So as with other any other medical condition, what are the various points? So that I am going to highlight. So here, second generation antipsychotic. First, we need to know whether first generation or second generation. So when the SGA, when initially it came, it marketed as more effective and tolerable than FGA. However, quality of measure between second generation, the previous one, quality of measure, that is between the second generation antipsychotic and first generation antipsychotic, they presented conflicting result, that which one is more potent. So some people says that no, because first generation drug has EPS, so SGA is better. But with SGA we have metabolic syndrome. So there is no conclusive till now. We don't have any in comparison to this first generation antipsychotic. Meta-analysis of 57 studies have shown that SGA reduces the annual incidence of. It is true that in terms of tardive dyskinesia or EPS, SGA is definitely better than second generation antipsychotic. So next slide, please. Next slide, please, Adil. So which one? Now, a meta-analysis of 150 double-blind studies, they have found that clozapine, olanzapine, risperidone, and amisulpiride, they were significantly more efficacious than first-generation antipsychotic. Whereas among second generation antipsychotic, among them it has there were no significant differences found. So in general, SGA has a class as cause greater metabolic adverse effect with reduced risk of movement disorder. Although there is substantial variability between the individual medication, it between the individual medication occurs. Like if we differentiate between quetiapine and both are pines, olanzapine and quetiapine. So the weight gain property is more with olanzapine than with quetiapine. So individual variation is there. Next slide, please. So what are the factors which we use to select a medication? It is efficacy, tolerability, effectiveness, then non-adherence, then preferred route of administration. Next slide, please. Then cost of treatment, then past treatment response. We also see that, okay, this patient was having good response with this particular medication. So this time also we will go for that particular medication. So also we need to take care of whether what kind of medical morbidity a person is having. Then of course treatment resistance, what kind of medication person has been given, and whether what was the response, whether he is fit for treatment resistance or not. Then another, what is the patient and family preference? So these are the factor which is used to select medication. Next slide, please. So now we come to what is the evidence based. So I have put some studies. So what meta-analysis has to say about the antipsychotic medication, and it has been seen that this clozapine, it has got superior over other treatment option. The mechanism, although it also acts on same receptor, but it is not known why this clozapine is superior when it is compared with other antipsychotic medication. Then we have olanzapine, risperidone, and amisulpiride. They are significantly more efficacious than first generation antipsychotic and most of the other second generation antipsychotic. So if efficacy wise we have to choose, it is among second generation, it is olanzapine, risperidone, and amisulpiride. Then the next, third important point is that the remaining antipsychotic are having similar, they have similar efficacy, and some evidence it has been suggested that quetiapine and ziprasidone may be inferior to other second generation antipsychotic, though quetiapine often used under doses due to sedation. So because for quetiapine it has been said that between 25 to 50 milligram it has got hypnotic response, then from 50 to 300 milligram it has got antidepressant effect, and then 300 and onwards to till 800 milligram it has got antipsychotic effect. So the reason could be that it has not been used in a proper dose as an antipsychotic dose because of side effect of sedation. Next slide. Next slide, Sajid. So this is again efficacy about the say among first generation and second generation, and it has been found that second generation has is better in terms of negative symptom, and first as we know that because it does not have first generation has no effect on serotonin receptor, so definitely it has low, it has poor, it has poor outcome in for negative symptom. One other drug which has come up recently, that is third generation cariprazine, has shown it is very good. It has been shown that it is a very good drug to improve negative symptom, and but not for positive symptoms. So many a times cariprazine it is mainly used as a as an antidepressant in bipolar depression. Next slide. Next slide, please. So, one thing is very important, that before determining that this particular treatment is less efficacious or more efficacious, we need to give the medication in a proper dose for proper duration. So, dose has to be optimized, and it has to be given for at least 6 weeks, or in case of clozapine, it has to be given for at least 12 weeks. Next slide. Now come to next slide, please. Sajid. Sajid, next slide. So now come to if we compare which drug is more tolerable. So rise of second generation antipsychotic has come up with the at the expense of first generation only, that okay, first generation has got EPS, so this second generation has come up. So it has been seen that with second generation the chances of there is less chance of EPS and tardive dyskinesia, while being highly efficacious. Clozapine and olanzapine, they cause greatest weight and blood glucose level. Possibly, as my previous speaker has already mentioned, that because of action on 5-HT2C and histamine receptor, that is H1, the level of blood glucose rises, and it also causes obesity. So, the most dramatic weight gain has been found with during first week of first 6 week of treatment in antipsychotic naive patient, and it is basically more with clozapine and olanzapine. Next slide. Next slide. So in case of tolerance, the lurasidone and ziprasidone, and it is followed by aripiprazole, and it causes least increase in blood glucose level and weight gain. So weight gain is least with ziprasidone, lurasidone, and aripiprazole. Again, in case of QTC prolongation, ziprasidone, amisulpiride, cetridol, this has not come up. It is not present in the market. So ziprasidone and amisulpiride, it causes most QTC prolongation, and although amisulpiride is very well tolerated drug, but few patients may show this QTC prolongation. Next drug is this pariperidone and risperidone. They have high rates of dose-dependent EPS. As you will increase the dose, there is more chance to develop extrapyramidal side effect, and also there will be increase in prolactin level, and that may cause galactoria and amenorrhea sexual side effect. Next slide, please. Next slide, please, Adil. So, haloperidol is another among SGA. It is the another drug. It has got high rate of EPS, and it is the main all cause. This is the reason of all cause discontinuation, and it has been shown in CATI trial, and where but it has been compared with the mid potency first generation antipsychotic. It has not been compared with the high potency drug. So that could be one of the bias or one of the demerit why this haloperidol has got high rate of EPS, because it has not been compared with the equally potent drug, equally potent antipsychotic. Yes, next slide. So, in terms of effectiveness, how do we, what is the difference between efficacy and effectiveness? That all cause time to treatment discontinuation has been accepted as a proxy measure of effectiveness. So, effectiveness combines this antipsychotic adherence, efficacy, and tolerability. So, tolerance, efficacy, and antipsychotic adherence, these three combine, and it is the measure of effectiveness. So, again, we can see in this slide that the person, the meta-analysis of about 53,000, roughly 53,000 patients with chronic schizophrenia, and it has been found that dropout or non-adherence is basically not because of inefficacy, but it is because of patient could not tolerate its side effect. So, and which drug is mainly which drug this haloperidol is the drug which is mainly responsible for dropout, and it is significantly lower with other drugs such as amisulpiride, olanzapine, paliperidone, olanzapine, but it is more with haloperidol. So focusing exclusively, it has other meta-analysis, it has been found that identifying clozapine, olanzapine, and risperidone, it has been found superior to several second generation antipsychotic, and but yes, quetiapine was inferior to several. These findings are basically I am quoting from meta-analysis. Next slide. So non-adherence. What is the reason of non-adherence? Reason could be side effect burden, lack of insight. That is very common in schizophrenia. They sometimes they think that how long they have to take a medication. So poor psychological intervention, or they have psychoeducation. They have not been informed properly, or maybe drug has not effective. That even after taking medication, they are not the symptom is not improved, so they might stop taking medication. So there are a number of reason why they stop taking medication. So next slide, please. Next slide. So because of non-adherence, there are a reason I have already discussed. So because of non-adherence, this like first episode psychosis is of particular important, because if response rate fall dramatically during subsequent psychotic episode, if you have not treated properly the first episode psychosis and a person has stopped taking in between, then when that patient develops second episode of so psychosis, though the response rate, as I said earlier, that response rate is only 20%. So again, this could be one of the reason. And so medication non-adherence is associated with fourfold increase in the relapse after first episode psychosis. So we need to optimize and individualize treatment to improve the adherence, and it should be primary goal. And how can we improve the adherence? So one option is, yes, we have long-acting antipsychotic. Next slide, please. Next slide. So cost of treatment is again another point. We discuss about selection of medication. If you prescribe very costly medicine to a poor patient, so he won't afford it, and then ultimately he will leave. He stop taking medication, and that will lead to further further decrease in his quality of life, and his symptom will increase. So this cost of treatment, we need to it is the important factor we need to take care of. Next slide, please. Next slide. So I'm not going to discuss it in detail, because it has been calculated that how much money should be invested in a month. So for amisulpiride, it is about 2,000 rupees. But I don't think it has been converted. I think it is amisulpiride is very costly drug. But yes, olanzapine and risperidone is a drug which has got less price. So olanzapine and risperidone can be prescribed in long-term basis for poor patient. Next slide, please. Next slide. So overall summary. This slide is very important. So if a patient is having, so apart from the parameter which I discussed earlier, that is efficacy, tolerability, and then effectiveness, then cost, non-adherence, we need to see these are the parameters by which we can select that which medication has to be given. So if a patient is having some metabolic problem, so we can think of ziprasidone, and we can which drug which should be avoided. Drug like olanzapine, clozapine, then iloperidol. So we can see that which drug has got most side effect in terms of metabolic disorder, and which has got least. So if a patient is having metabolic disorder, aripiprazole, loracidone, and ziprasidone is the would be drug of choice. In case of prolactin increase, so which has got most this risperidone is notorious to cause prolactin elevation, and then amisulpiride, then haloperidol. So these drugs we need to avoid. And a drug like quetiapine, flufenazine, aripiprazole, clozapine, we can give in a person who is prone to develop this prolactin elevation and sexual side effect. Then a person who is prone to develop extrapyramidal side effect, so we need to avoid first generation antipsychotic, and we can give them to aripiprazole, then olanzapine, then clozapine, and yes, brexpiprazole, that is third generation antipsychotic. Then akathisia. With akathisia, similar to extrapyramidal side effect. So we need to avoid first generation antipsychotic, and we can give olanzapine, quetiapine, and clozapine. Now, person who develops QTC prolongation, we need to avoid amisulpiride, ziprasidone, then iloperidone, acinapin, but we can give the third generation antipsychotic like aripiprazole, brexpiprazole, lurasidone. The person who has got who are prone to develop sedation, so they can be given again aripiprazole, paliperidone, and we need to avoid zoclofenthizole and clozapine and quetiapine also, because they are prone to cause sedation. So this is all about all about the various antipsychotic, and which antipsychotic we need to choose. It depends on so many factors, so many things. So before prescribing antipsychotic drug to a person with psychosis or schizophrenia, we need to be very careful. We need to do various investigation, baseline investigation, and then only we will decide which antipsychotic has to be given. So thank you, sir. This is all about how to select. So yes, another slide I am having. This what I wanted to discuss. That is treatment-resistant schizophrenia. It has been the drug of choice would be not drug of choice. It is the clozapine. It has been shown to have greatest efficacy in treating schizophrenia, and this is considered gold standard treatment of treatment resistant schizophrenia. So first there should be there is criteria for treatment to be called as treatment resistant schizophrenia, though that two antipsychotic of different mode of action has to be given for at least 6 to 12 week in optimal dose, and if it does not respond, then only we call it as treatment resistant schizophrenia. And it is not known why this clozapine works, because it is the receptor is the same. It acts on D2 receptor, it acts on 5-HT2A receptor, as well as other H1 receptor, M1 receptor, and alpha adrenergic receptor. But why it works on treatment resistant schizophrenia, it is still not known. So this is all about antipsychotic antipsychotic drug treatment for schizophrenia. So I move to thank you. I hand over mic to Bhavna. Yes, Bhavna. Thank you.
Thank you, ma'am, for that excellent session, helping us understand how to choose the best drug profile for our patients. And now we move forward. I would like to invite Professor Dr. Pankaj Sir, Professor and Head, Department of Psychiatry, AIMS, Patna, to share his expertise on personalized treatment for schizophrenia. Sir, with his 19 years of dedicated professional experience and distinguished background as the past president of IPS, Bihar State Branch, he brings a wealth of expertise to today's session. Welcome, sir.
Am I audible?
Yes, sir. You're
So you're
slightly
audible.
audible. Slightly audible.
Okay. Is my slide visible also?
Yes, sir.
Okay.
But I put it in slideshow mode. Otherwise,
Yeah. I'm doing that. Now my slides visible?
Yes, sir.
Okay. Okay. Good evening, everyone. And once again, thank you. And my gratitude to ASP IGIMS for giving me this opportunity to today talk among the distinguished pharmacology experts and scientists and researchers. And I'm particularly happy that this time they have chosen a topic which is not very well accepted, well talked into the field of mainstream pharmacology. Mm. Uh, so, with that brief, I'd like to start my presentation. And since my previous presenter has mostly talked about the available medications, their level of evidence, their efficacy, safety, and how to consider choosing or selecting the drugs depending upon the various aspects of tolerability, safety, and efficacy as well as effectiveness. So my topic has been given a personalized treatment for schizophrenia. So this is, as we have discussed, and it has been already discussed by previous speaker, and we are now enough versed, particularly to my audience, that there is a host of antipsychotic drugs which has developed in last 7 decades, and all drugs have mostly been remain centered around dopamine hypothesis and dopaminergic agents, directly or indirectly through second generations. And those second generations has given us some other beneficial benefits apart from the antipsychotic efficacy. It has given us a good safety and tolerability profile, as well as some better effect on the negative and cognitive symptom aspects. When we talk about the personalized treatment, in the psychiatry field, it means a different at this stage. It means that we are not treating the disease, we are treating the individual. So their individual is not only about his symptoms, his delusion, his hallucination, his aggression, his mood swings. These are not, that is not the only concern. What are the experiences of the symptoms to the individual? How distressing are those? What are the impact of those symptoms to the individual and the family? And how these symptoms bring about significant decline in the individual's personal life, occupational life, and social life. So we can say overall quality of life is very much decreased. So, in personalized treatment talks about holistic care of approach, taking care of all these needs, not only taking care of symptom reduction. So that is the broad concept under the broad rubric of biopsychosocial model. So biological by treatment or pharmacotherapy, but psychological and social aspects needs to be equally taken care of. But since this is a pharmacological update seminar, I have taken a different route today. And I'd like to talk more about the personalized treatment in the context of the precision medicine principles, which is more developed into the other branches. Particularly in the last 1 and 2 decades, we have seen the rise of immune marker based and guided cancer therapy, which has significantly changed the landscape of the treatment selections and the response to the treatment in cancer patients. Similarly, in cardiovascular disorders, the cardiovascular risk factors and how by different biological means targets newer drugs, those risk factors can be minimized. So these are the basic, very, very landmark things which has happened into the other aspects of the medicine. But unfortunately, into the psychiatry, as my previous speakers have highlighted the complexity of the nature of illness. So that is there, and we don't still have the enough definitive answers about the what is causing, what biology is driving this schizophrenia. So unless until we have the definitive response, the kind of precision treatment we are going to discuss is a bit difficult to assimilate in today's time. But I would like to start and I'd like to delve into the two, three only aspects in which there have been significant development in last 1 decade, and they are still at the level that it has not reached to the level of translation to the our clinical practice. So why? The case of personalized treatment in schizophrenia, I think most of the things have taken care by previous speaker. The most important part is the clinical heterogeneity of the diagnosis of schizophrenic patients. As you have talked about, our diagnosis is primarily based upon the constellations of symptoms and signs, and we call it a disorder. So, but when it comes to the treatment response, the course of the outcome has a diverse trajectory, diverse course, diverse outcomes. And why this is happening? Because we don't have still the definitive response, definitive answers. Are we treating the disease or are we treating the disorder? So that's the major question which is there and which makes the case for today discussing the personalized treatment in schizophrenia. So what are the unmet needs for personalized treatment in the field of psychiatry overall, but today we'll talk about schizophrenia. As I've told earlier, we don't have definitive understanding of underlying neurobiology or pathophysiology of schizophrenia. Until now, in last 7 decades, we are only working prescribing drugs based on the principles of trial and error approach. And one size fits all. Once a schizophrenic, all schizophrenics, the antipsychotics, whether it's first generation or second generation, depends upon the person's choice, the individual's clinician choice, patient preference, and some amount of different aspects which my previous speaker has detailed about. But even with all these advancements, we have failed to achieve the adequate outcome as he has talked about, and I presented in my previous slide that the more than one third, still after host of multiple trials, they are not able to show any response. And even the people who are showing response, among 40 to 60%, they have the residual symptoms, either in the form of cognitive symptom, negative symptom, depressive symptom. So overall, their quality of life, their recovery is not yet up to the mark. Now, what are the issues? Why we are struggling? The most important thing is nosological issues or classification and diagnostic principles in psychiatry are fundamentally devoid of a biological approach, which we have taught. Though in last 2, 3 decades we have gained better knowledge and understanding of the neurobiological aspect, but still it is limited by a lack of generalizability, reproducibility, and translational value for inclusion into the clinical guidelines. And we have talked about the reason behind it, the huge amount of clinical heterogeneity among the current diagnostic category of schizophrenic person. So, when it comes to the personalized treatment or precision treatment, there is a dire need for treatment targeted and tailored to the individual needs, which is based on the genetic biomarker or phenotypic characteristic. So with that uh, background, I'd like to proceed further, and I'd like to keep my presentation into the three intersecting themes which will help us understand the current state of precision psychopharmacology into the field of schizophrenia. So one will be biomarker-based stratification to a distinct neurobiological subgroup based on QEZ markers or imaging markers or genetic markers or immunological and metabolic markers. Until now, whatever information we have gathered from this biomarker newer novel targets for pharmacological agents are into process of development, so which I'll talk about later. And third part will be endeavor should go to make this biologically in need for prescribing pharmacology into innovations of schizophrenia. So coming first to the EEG or ERP-based biomarkers, because these biomarkers since last 6-7 decades has been tried as a part of developing some kind of biomarker which gave us either some prognostic marker or marker identifying response to treatment. Most important of that is mismatch negativity, and reduced amplitude has been seen and has been adequately evidenced in schizophrenia, and it has found to be correlated with the NMDA dysfunction, which ultimately lead to glutamatergic dysfunctions. And P300 amplitude reduced, which leads to cognitive deficit, and it has helped us track antipsychotic response and improved. We can track the responsiveness improving with antipsychotic use or not. Similarly, GABA-based quantitative EEG ASSR, and their reduced power, particularly in the pulvirine interneuron, they are significantly found to be correlated with significant cognitive dysfunction, and that makes it a good guide targeting for neuromodulation. ERN is another important candidate phenotypes for negative and cognitive symptoms. So these are the few findings which were initially scattered but was not found to be very specific and sensitivity to be applied clinically. But into the recent time, in last 1 decades, now people have started using a different way to collecting and composite biomarker methods to subtype neurobiological the schizophrenic diagnostic group. And one such consortium is BSNP. It is called the Bipolar Schizophrenic Network for Intermediate Phenotype. So I a bit go into this based on it. This is a consortium which was developed in USA, and they are doing it since 2017. They have been combining the neurophysiological, the cognitive marker, the clinical phenotype markers, and combined together, they have developed a different biosubtype, and they have categorized 3 subtypes, 1, 2, and 3. And they have categorized based on what this biotype 1 means. One people neurobiological category of biosubtypes 1 have found to have severe cognitive and sensory processing deficit and markedly reduced electrophysiological findings, and they are found to be very close to classical neurodevelopmental trajectory, which is more being seen in transmitter neurochemical direction related with NMDA hypofunction. The biotype 2 is more related to and has found to have at least intermediate neurophysiological profile, and the cognitive deficits are moderate. And there are prominent affective and mood dysregulation, which has been found to be characterized in biotype 2 people. And their structural brain changes are also intermediate, not as severe into the biotype 1. And biotype 3 are having the near normal cognition with the near normal electrophysiological profile, and they are mostly having positive symptoms predominant, and they have a better prognosis. So based on these three biosubtypes, they have given a prediction of likelihood of treatment response pattern and suggested pharmacological strategy. So biotype 1, based on electrophysiological finding, you can see one has significant and strong cognitive deficits and significant dysfunctions in that category. So that is called a dull brain. They show poor response to a standard D2 antagonist, and they have high risk to develop a treatment resistant schizophrenia. So they suggested B1 category neurobiological subtypes. The clinicians should consider the early introduction of clozapine and also NMDA based adjuncts, because there is significant cognitive dysfunction which is related to neurodevelopmental deficit in NMDA hypofunction, and muscarinic and agonist which will be more beneficial for cognitive domain. So these are the basic suggested pharmacological strategy for B1. B2 group, because they are called a noisy brain, their brains based on electrophysiological finding, they have been labeled as noisy brain, and they show variable response and mood symptoms are very often persist. So in that category, antipsychotics along with that mood stabilizing profile, particularly the cariprazine, lirasidone, SSRI, SNRI, they can be used as an adjunct for effective component treatment. The third group is the reactive group. Their electrophysiological profile is normal. So they show generally good response to a standard antipsychotic. So normal D2 antagonism based or dopamine serotonin antagonism based antipsychotic will show favorable response, and they are having good functional recovery with the treatment, standard treatment, which can include even a basic psychosocial treatment, will also be helpful for them to become functionally recovered. So this is how this biosubtypes has given us some kind of initial findings to suggest how to start and what kind of pharmacological treatment strategy should be adopted in these different subcategories. Now, this is another genetic marker which has also been significantly developed, and these are whatever findings I am talking today is based on the series of meta-analysis and their crux of finding. So another important this finding is about the polygenic risk score. We all know that it's schizophrenia is the polygenic disorder. So it's not the one gene, but multiple genes and genomes, and it has come up with the large-scale genome-wide association study and their meta-analysis by the Psychiatric Genomic Consortium group on schizophrenia. And they have given us this polygenic risk score based on the number of the alleles which are there, which is conferring or adding or multiplying the risk. Based on that, they have developed this risk score. So what does this risk score imply? The higher degree of score, the more difficult it will be that person will respond to the treatment. They are told that top 10% of those high PRS score people will have significant high risk of schizophrenia development as compared to the normal population, and they will be associated with the treatment resistant schizophrenia, and elevated PRS will be associated with early age of onset and steeper cognitive decline. So again, whenever we have a person whose PRS score is coming higher, so it will give us indication right from the beginning that this patient is unlikely to going to respond to our conventional antipsychotic regime. And most probably a better practical strategy will be go to the higher or novel mechanism of medication, particularly the early initiation of clozapine. But when it comes to the Indian context, we have to keep in mind the caveat of translationability of this particular PRS score, because whatever this genome-wide meta-analysis has happened, the contribution of the Indian data is very, very less. So local validation is still required to apply it in our Indian population. Now, another important area is neuroimaging based biomarker findings, which has been done by Enigma Group. And this is also enhancing, this group is working on the principles of enhancing neuroimaging and genetic biomarker by meta-analysis. And they have been conducting series of meta-analysis combining huge amount of data from all over the world. And that crux of the finding I'm putting here. So structural MRI finding predominantly talk about gray matter volume loss in frontal and temporal cortex is very much characteristic of this particular schizophrenia group. Similarly, resting state fMRI meta-analysis has shown DMN hyperconnectivity and salience network dysregulation as a significant stratification marker. Because when these people, these kind of findings, again, we have to think about a different approach, not only pharmacological, but also the early introduction of various kind of neuromodulation approach will be much helpful in this category of patient. DTI predominantly show us the reduced white matter integrity, which is found to be well correlated with the cognitive deficit biotypes. MR spectroscopy, MR finding, meta-analysis finding has led to finding of elevated prefrontal glutamate and GABA ratio, and which is again indicative of NMDA hypofunction signature, and again predicts poor response to conventional and early introduction of either NMDA based pharmacological agent or other kind of neuromodulation agent. Neuromelanin is again a metabolic product of the dopamine, and neuromelanin MRI, which gives us a better idea in predicting the risk of conversion of high risk group to the frank psychosis. So it is basically a marker for dopamine synthesis. High degree of dopamine synthesis, there will be high amount of neuromelanin deposit into substantia nigra, and that can be picked up by the neuromelanin MRI. So these are the different broad currently biomarkers that has been identified and has been shown to have some promise to have potential for translational value. So overall, apart from biological, pharmacological, all these neuroimaging related marker gives us a better idea to have a good target, identify a valid target for tailor personalized neuromodulation therapy, which can be added along with the pharmacotherapy for early response and the better recovery in such category of patient. Now, pharmacogenomics, which is well advanced in other aspects of the other branches of the modern medicine, but in psychiatry it has lagged behind. There are many reasons for that. Even the psychiatrist's role having lesser idea and knowledge, not having much belief into the clinical utility of pharmacogenomic based treatment decision is also one of the regions. But even international consortium of the pharmacogenomics, they have been trying to form a consensus statement, and based on that, I am presenting this table that mostly the pharmacological metabolizing enzyme, which is primarily most of the antipsychotics are metabolized by cytochrome 450 enzyme system. And in that particularly, this consensus statement says CYP2D6 is the most important, and the genetic variations into this particular CYP2D6 has significant implications for deciding the dosing and also predicting the side effect potential of starting a particular pharmacological agent in that particular patient. So based on the pharmacogenomic profiling, they have found that there are poor metabolizer or ultra rapid metabolizer. So according to that, and most of the CIP2D6 study has been extensively done mostly into haloperidol, risperidone and aripiprazole. And they have said that if they are poor metabolizer, toxicity as standard dose will be high. And when it is a rapid metabolizer, the subtherapeutic levels will be there with the standard dosage. Similarly, for the other drugs, there are CYP1A2 for olanzapine, clozapine, CYP3A4 for quetiapine, lurasidone, ziprasidone, CYP260, 2C19 for clozapine, though it is not predominantly metabolized by that, but still that genetic allele various polymorphism has shown significant alteration into the metabolism of clozapine. And most recently, HLA-B 50.01, that has shown polymorphism of HLA-B 1501 has found to be significantly associated with the high risk of hematological, particularly agranulocytosis with clozapine. So this particular, even the product level, which has been instructed by FDA into the antipsychotic prescription or antipsychotic drugs strips, that they should have this kind of labeling that if there are pharmacogenomics of HLA-B 15.01, people should be careful if it is there, polymorphism is there. So these are the gross finding till now. So based on these pharmacogenomic findings, people are advised they can go for deciding which drugs to start, in what doses to start, how closely we should monitor the side effects. Now coming next to the blood-based biomarker, particularly the inflammatory, metabolic and proteomic and other biomarkers. Among that, inflammatory markers, though have gained significant prominence into the recent research area, particularly the IL-6, TNF and CRP has found to be significantly elevated in acute psychosis. IL-2 receptors have been found to be correlated with positive symptom severity. And minocycline trial has been also shown some promise in negative symptoms where they have found a high titer of inflammatory markers in particular patient. So overall, based on immunological and inflammatory markers, person can be also stratified into those having high inflammatory marker, those having low inflammatory marker. So people with high inflammatory markers can be given adjunctive anti-inflammatory drugs. Among that, minocycline has shown some initial promise, but other things, other results of other anti-inflammatory interventions have shown the mixed results. So still we don't have the enough evidence to use it in our routine clinical practice. Among the metabolic and oxidative stress marker, glutathione, homocysteine, lipid peroxidation, and omega-3 fatty acids, all these three markers are identified and found to having significantly higher into a schizophrenic patient subgroups, but still we don't have enough evidence for use into the routine clinical practice. Similarly, neuroproteomic and protective factor BDNF and NGR1 signal variations in serum has been significantly found to be associated with decreased synaptic plasticity in some category of schizophrenic subgroup patients. So now coming to how this kind of information which we have gathered from genetic, inflammatory, other blood markers has helped us trying to find a new targets of antipsychotic interventions, and accordingly people have started trying to identify innovative targets. Among that, I'd like to talk about the one drug which is called as the Cobenfy, which is a combination of xanomeline and trospium. Xanomeline is primarily a M1 M4 muscarinic agonist. And this is the first drug which has been approved by FDA in 2024, which doesn't have any effect on D2 blockade. So it is considered a watershed moment, a watershed event into the pathway of the discovery of newer targets and newer drugs which can be efficacious and which doesn't have side effects, which we keep on fighting while we are dealing with the D2 related antipsychotic drugs. So there are two emergent 1, 2, 3 trials. Has all these trials have shown significant efficacy and tolerability of this particular drug. So this is a very important new drugs which is likely to be introduced soon into the Indian market, and it will also help us particularly in those with cognitive symptoms and negative symptoms. So similarly, based on those findings, we have now host of new innovative targets, which primarily leads to group of targets are primarily 2, 3 targets, which is more promising. I'll try to talk about that is TAR1 agonist. That is the trans-amine associated receptor agonist. M4 receptor agonist, we have already talked about one agent. Other agents are also into the process of phase 2, phase 3 trial. NMDA receptor is another important target, either through the glutamatergic receptor, either through NMDA or through AMPA receptor agonist or through glycine transporter inhibitor receptors. So all these are working predominantly on the glutamatergic. The GABAergic receptor modulators as well as sigma receptor modulators. These are the newer innovative therapeutic targets which has been identified, and various class of drugs into the various stages from preclinical to clinical phase 1, 2, 3 stages are there into the pipeline. I'd like to give some highlight about the important which are into the phase 3 aspect, phase 3 level. Among that, emraclid, which is an M4 positive allostatic modulator, iclepertin, which is an NMDA co-agonist which works by glycine transporter inhibitor. Similarly, uloteront, which I was talking about the TAR1 agonist, that has also been found to be very promising, and still they are into the phase 3 level, and probably particularly the uloteront is showing a good promise into the initial findings of the phase 3. So all these are ongoing, and most likelihood in coming 2, 3 years, among these drugs, we'll have 1 or 2 drugs which will find some place into the regular clinical guidelines. I hope so. So now coming to the last part, the newer era of AI and machine learning. So this era and bioinformatics, they have whole lot of opened the new frontier to develop a precision medicine for psychiatric disorder, which includes schizophrenia, particularly MRI-based machine learning, EEG and AI-based biotyping, multi-omics integration-based machine learning model, digital phenotyping, federated learning. All these are different kind of machine learning models which are now being used, which combines all different modalities of markers. because till now individual markers are not able to find enough replicability and generalizability to be included into the routine clinical practice, and their specificity was also very low. So that's why now people are trying to combine all these things together through the process of AI and machine learning. And through that, we are expecting to hope some good breakthrough into the coming future. So AI trained on large, the main issue with the AI, challenge with the AI is the data sets. And particularly the South Asian and Indian data set is very, very less when we talk about the large amount of consortium which are working across the world on the different aspects. Some consortium are working on genetics, some consortium are working on multi-omics, some consortiums are working on EG. There are large consortium, but South Asian and Indian data sets are very, very less still. So translational value of these findings will still be not very validated into the Indian context. So that's an important thing we have to keep in mind whenever we are talking about the findings related to AI and machine learning based new frontiers into the field of precision medicine. Now, coming to some amount of talk about the Indian context, as I talked, the South Asian and Indian population is very less represented. The easy normative data is not very rich here. And also, if you talk about the pharmacogenomics, it is well known that CYP2D6 polymorphism is one-third of psychiatric patients from Indian origin are having a poor metabolizer, and they can benefit from pharmacogenomics guided dose adjustment and the selection of the initial selection of psychotherapeutic agents into the schizophrenic patient. So with these backgrounds, there are suggested roadmap by some people, some experts who are working relentlessly through meta-analysis methods, trying to develop the biomarkers, biosubtypes, biosubcategories within a larger group of schizophrenic diagnosis. And they have framed a certain roadmap for coming 10 years. So in 25-27, a standardized B-SNP QEZ protocol, which I talked about, established PRS threshold for TRS prediction, treatment-resistant schizophrenia prediction. In the next 3 years, biomarker, which will include all omics-related biomarker, and prescribing RCT, which will be based on the biomarker-guided and pharmacogenomic panel combined together, and then doing the RCT of the novel targeted pharmacological agent. And last into the 2030 to 35, multi-omics decision support tools, which is powered by AI, which will help us even without having the enough baseline data. Those AI-based algorithms can be used into the any other data, which will help us make these tools available all across the globe to help make the treatment more equity focused, health system integration based. So at the end, the key takeaways from whatever till now I have tried to develop, B-SNP biotyping is having a potential to carry distinct treatment implications from early close-up in B1 to a standard agent in B3. PRS again will flag treatment-resistant trajectory and close-up in eligible patients earlier. Pharmacogenomics guided dosing will help us guide dosing, reduce toxicity and non-response across antipsychotic classes. Non-dopaminergic pharmacology into the pipeline will open a new mechanistic era beyond D2 blockade. And local normative data in India And there are certain initiative in India which is happening as a park initiative and other initiative which will be essential for making all these findings which are coming more equitable, more validated for the Indian patient population also. So at the end of it, till now, whatever I have presented is having a promise level, not coming to the prime time level of clinical translation into the clinical guidelines for pharmacotherapy, which should be guided by the neurobiological findings, so neurobiological subtypes. But we can till now, whatever things are aspirational, what can be aspirational precision model? So first we need to stratify based on biomarkers. The patient, the group of schizophrenics must have biomarker-based test battery to stratify those patients into the distinct biomarker subcategories. And structured biomarker workup should comprise of CYP 450 genotyping and PRS computation, baseline inflammatory panel including CRP, ILC, resting state QEG and ERA-based biotyping, structural and functional MRI-based and digital phenotyping. Now, combining together all this phenotyping based on the whatever I have talked, we can have precision subtype assignment which will help us decide individualized drugs and adjunct treatment drug selection for this one particular individuals. So B-sleep biotypes will help us define cognitive effective treatment lane. PRS will flag early TRS clozapine eligible patients at the earlier stage. Pharmacogenomics will fine-tune our initial choice of drugs and their dosing. So this kind of aspirational precision model based on stratification of schizophrenic patient into various biological subtypes category is coming forward and is in pipeline and have potential to come up into the coming near future based on the current level of understanding and knowledge. So with that, I'd like to end my presentation and thanks everyone for the kind attention. I'd like to end that yes, we need to change our way to ask question, research question, because that is the only way we can better make precision psychiatry a reality. A precision treatment a reality for schizophrenic also. Normally, we are more invested into what diagnosis does this patient have. But we need to change this with the research question, what biology is driving this person illness, irrespective of what kind of psychotic disorder. And that biology should guide the treatment decision. So once again, thank you everyone for the kind attention. Hand it over to the moderator for further. Thank you very much.
Thank you, sir, for emphasizing the importance of patient-centric care, moving away from one-fits-all to tailored medications. Now, to bridge the gap between the research and the clinic, I invite Professor Dr. Vikas Medi, sir, the chairman of IOFA PGIMR Chandigarh, to address preclinical to clinical aspects of schizophrenia. We are honored to be joined by him. He is a distinguished leader in pharmacology and a globally recognized scientist ranked among the top 2% worldwide. With an intensive career in spanning academia, clinical research, and national policy making, Sir serves as the chief editor in multiple prestigious journals, and he is a key advisor for organizations like IFA and WHO. It is a privilege to have such an accomplished expert to share his profound insight. Welcome, sir.
Can you unmute me from the laptop? Another device. You have to unmute.
Yes, sir.
You are unmuted, sir.
No, from mobile it is unmuted.
Okay,
Laptop
okay.
you are not able to unmute.
Okay, sir.
Another device, laptop.
Now you can unmute yourself, sir.
Okay, thank you. Thank you.
Yeah.
I'll just upload this one. Okay, so can you hear me?
Yes, sir. Your screen is also visible.
And just check my slide is moving or not.
Move it, sir. We will confirm.
Is it moving?
Yes, sir.
Moving, sir.
Okay, so thank you very much. So while we are discussing about this, symposia. So last time we had clinical trial day we celebrated. So we wanted to do it on a particular topic, schizophrenia, as all the psychiatrists friend must be very happy that we need to work with a team, with a pharmacologist. So one of the important component that is not there is TDM for antipsychotic and antidepressant. So you can read that. So I just wanted to say that in a couple of minutes, maybe I have around 15 minutes or 20 minutes. How much time you have allotted? How much time you have allotted? Can you hear me? Okay.
You are audible.
Yeah, no, how much time you allotted it? Accordingly, I'll do that.
15 minutes.
20 minutes, sir.
20 minutes, fine. So just to given, because many of the medical colleges do not have an animal facilities. And that is why I just wanted to say that when you go for any meeting, so where that animal facilities is there, just go around. And also when you go to metros, so you have a GLP facilities, you can also go around. So at least how they do the proof of concept studies and preclinical studies, you can go around. So you might have listened to many of these speakers, start from Dr. Lalit and other speakers about the drug therapy incidents. So obviously we have national program on mental health. So worldwide, if you look at that, at least one person. So you need to also look at that because there are a lot of gray areas when you look at the pathophysiology that also need to. But one of this very interesting that any topic I said, I just dig out that historical data. So if you look at the historical aspect, James initially, 1800th century, that he described, one of this person who actually admitted into the hospitals. So that was the background history, well documented description of remaining, paranoid schizophrenia. Later, if you look at that email, he also, because initially it was thinking that, autistic was also schizophrenic, but later it was found something is different. So that's how it is 1908 that term was coined schizophrenia from the Greek word, schizont, it is split, uh, mind split. And that's how there's a historical aspect, you can look at that. But fact of the statistics, that, number of people suffering from mental health, and particularly when you talk about schizophrenia, is more than 20 million. So here, if you look at the risk factor, because when you create a model, you have to also know that what could be the pathophysiology. Accordingly, you can think of that how you go ahead. So you can see that genetical aspect is there. So earlier speaker, Dr. Pankaj had already said that, pharmacogenomic aspect. And I just also request because we do a lot of testing like, genomic studies. So the PG students should also look at, pharmacogenomic, and it should be pan-India study. It's not only in Bihar or UP or some isolated. It should be pan-India. So one thing is the familial history. As you can see that there are a lot of, responding to the treatment, those who are slow acetylator or, genomic differences there. Then if you look at that, some of the toxin it is exposed. So if you can identify the toxin, then during the birth and also psychotropic agent, and there are other factors there, smoking. So this need to be identified. So here, if you look at the core symptoms, you have a positive, you have a negative, and here I'm just putting it that how these symptoms, whatever you do in a preclinical study, you are going to correlate with the preclinical, behavioral parameters with the symptoms, which is done because any of the model you develop, you always say how about you look at the construct validity, phrase validity, and predictive validity, and that is why whatever obviously you understand in human also there could be a lot of variability, but on an average, the positive and negative symptom, and that would have to correlate with animal model when you do it animal behavior. And as I said that we actually can conduct around 40 animal behavior, but let's understand that neurobiology of schizophrenia. So one of these hypotheses is it affecting the dopamine? Answer is yes. So you have a mesolimbic dopamine query with a positive symptom, or it is decreased, you have a negative symptom. Similarly, if you look at the glutamate hypothesis, so you have number of drug like NMDA receptor hypothesis, then interneuron dysfunction, then cortical inhibition, and that lead to the psychosis. And similarly, when you talk about excitatory and inhibitory, also GABA. So there is an dysregulation, and because of dysregulation, it might also affect the cognition. So this is also very important because younger population, when they have, then you have to also look at the cognition. Now, quickly go to the clinical guideline for schizophrenia. So as you can see, that symptom exists, delusion, hallucination, disorientation, negative symptoms, if you could, like, and cognition. That three component you have to see. So when you look at the treatment, you start with that during the acute phase, how you're going to look at focus, connection, and then you go for a stabilization, then you go for a maintenance. Then question it is coming is how long, how many years, and should you continue lifelong? So accordingly, when you develop a model, you have to say that this drug, how long you can use. Is it for a short term? It is for a long term. Obviously, you understand that if you go for more than 6 months, that definitely you have to go for a long-term toxicity studies, and that's how you say that it can be given the long-term. So core principle of global consensus, if you say that to WHO, then National Institute of Health, or you say American Psychiatric Association, World Federation. So one part is that we have already discussed about pharmacological intervention with the earlier speaker. Then prescribing protocol, what should be protocol? Because you know that we refer it to Western setup, but how about India? Because quality of life or other factor is different. So utilizing monotherapy, whether it is possible, initiate with the lower dose, and definitely you escalate the dose. But you need to know that maximum tolerated dose also. That is why we do ADL monitoring, everything we do. So that's how we put it. So in case we Indian perspective, like look at the Indian Psychiatric Association recommendation about the pharmacotherapy. Obviously, we have a DHR guideline how you're going to do it in case of a particular diagnosis. Then how long you're continuing. So that you can refer it to DHR guideline or Indian Psychiatric Association. So the first episode, if you look at it quickly, the preferred antipsychotic that is you use is risperidone, olanzapine, aripiprazole, other drug. Then step 2, with the start low, initiate that effective. Then you titrate it globally, then you go for the next phase. So the clinical rationality of the stage you look at, and accordingly you maintain the dose. So, but we need to look at that in case of acute aggression. So I'll correlate with the preclinical data, also how you do it, severe agitation protocol, oral pharmacological management, non-pharmacological what. And there is also a, you can put it as critical alert, how you're going to do it in case of a respiratory and other, cardiac maintenance and baseline vital. So maintenance therapy, relapse prevention, because patient history, if you say the first episode, you have a continued treatment at least for 1 and 2 years. And that is a question mark, how long, how you're going to monitor. If the multiple episode is there, definitely will continue for more than 5 years, and therapy open lifelong also. So these are lifelong, you have to see that monitoring systems would be there. But now that the challenge it comes in treatment resistant schizophrenia, and that is why when you develop a model, basically you want all these drugs are already available. So we want that can you develop a drug which can be used for resistant cases, and that is what we have to develop a model where you can be treated. So other factor like comprehensive baseline ongoing monitoring, you can send a neurological monitoring, or you can send other symptoms monitoring, metabolic baseline, everything. But we need to have a mechanism for maintenance of ADR also, because these are very common, and that's how we say that how optimize the dose. You look at the dose, you start with slow dose, and you go for a TDM, therapeutic drug monitoring. So extrapyramidal side effect, it's common with haloperidol. Weight gain is another, and other comorbid condition also we're going to discuss, hyperlipidemia, sedation. So then we need a holistic care for the ecosystem, functional recovery. So you look at all this aspect, and ultimately you can see that in Indian setup, how protocols should be there. Now coming to animal model. So if you look at that animal model, we can create the model. One of this model I'm going to discuss is amphetamine model. Obviously, we use amphetamine where ADHD. But here, if you look at it, amphetamine, how it inhibits the dopamine reuptake, and thereby level of dopamine increases synaptic cleft, and you have a typical. But other model like glutamatergic model, so we use the ketamine, phencyclidine, MK801. One of these drug has been, we also had done a couple of studies for, cerebral ischemia, but this also, so there are also neonatal ventricular one. So here, if you look at that, non-pharmacological model which create, I again said that when you create a model, you can take a reference model, but you have to have a construct phase and predictive validity, how much it mimic. And again, I stress on that we need a model for resistant cases. So if you look at the prenatal, PRS model, and you can say the post winning social intervention, then isolation of the model. So there are several models is a maternal malnutrition model. So one of the risk factors when you look at that, is it smoking, is it alcohol, or all this, malnutrition? If it a nutrient deficiency is there, is it going to affect that? So as those students, we do not have any exposure to animal experiments. So definitely you can take a mice by, rat, and you need to know the species also. So in case of a mice, you have a commonly used Swiss albino mice. Obviously, you have a Balsi mice or you have a C57 mice. But in case of a rat, also you have a Worcester rat and Spark Dolly rat. So we need to know how to handle it. So this is how we actually train during the experimental procedure. In case of a rabbit and in case of a guinea pig, also they were obviously docile, but most of the model we used a rat. So here the guinea pig is most docile, so we use it. Now, typically, if we say that one of the experiment we trained the student that haloperidol, because in acute psychosis, when it comes to the casualty emergency, what do? You give a haloperidol. So that you simulate in a rat. Look at that first one, wherever. Otherwise, it is difficult to keep in a small position, in a same position for the rat. And you always say that any of the depression effect, if you see the drug has CNS depression effect, what is that? If you don't have any instrument or any of this technique, what you are going to do? Just do a loss of writing reflex. Loss of writing, it does means that there is a CNS depression, or it could be muscle relaxation also. So typically haloperidol. So if you develop a me too like drug, so same model you can use that, that it can be done and it will be remain in the sustained position, and all these parameters, we have to look at an endpoint. So all this, what we say that along with the treatment, if you look at that new drug you give, you always that endpoint, how long it's sustained in that position, and along with the behavioral parameter. So amphetamine model is very commonly used, and dopamine, it block reuptake of the dopamine, and that is why you can explain mechanistically the key part, how it develops a schizophrenic like. So another model, we use a neonatal ventricular hippocampal lesion model, and that also develop a schizophrenia. As I said, that when you develop, obviously you got prenatal stress is there, PRS model is there. This is also one of the model it is used. And another model is post-winning social isolation model, maternal deprivation. So yeah, one of the important point is that if you have a rat and they develop a pups, and you can always say that, like for this autism, you say take the book, cotton gauze from the mother bed, they can smell it. So this is one of the strays that if mother is not there, so maternal deprivation, so it is one of the factors. So you can look at the mechanistically how we develop a schizophrenia. So as I said that, not a single behavioral parameter is involved. You give a drug like haloperidol, risperidone, you say, does it cause a CNS depression? And at the same time, coordination. So that is why you say that you do a Morris-Water, like cognitive factor is positive, negative cognition. How do you do that? So you do a Morris-Water for memory, you do Rotadot for coordination, and you do for an anxiety, can it cause? Because there are a lot of, so there are 40, different, but at the same time, you have a scanning also. Now, animal has whole body scanning. You give a drug, you can say that what are the organ, how much it is. In a different interval, you can estimate. So you can do that rat MRI also, everything it can be done. So as we discuss that, when you look at the clinical situation, first episode, we have a second generation of, antipsychotic, risperidone, olanzapine, antipsychotic, acute psychosis in severe aggression, lorazepam, you have a olanzapine, then treatment resistant. And as Dr. Pankaj has already said, that we have a very good drug, clozapine, but there is a problem with agranulocytosis. So they are also said that if you do a study, how many people develop agranulocytosis, and can you identify initially before you? So that is what precision medicine we talk about. And similarly, frequent relapse, how you're going to go for a long-acting, injectable haloperidol, or you say that resistant symptoms, CBT. So these are, so if you look at the translational lab, so because we talk about artificial intelligence now, like many times in animal model, you find very good efficacy and it is found to be safe also. But when you go for a clinical, it doesn't work. So that's how you say that any CNS condition if you work, can you say drug is cross blood-brain barrier, drug is cross blood enzymatic barrier? So that's how in an animal model, when you have a target, so is it a targeted therapy, lead compound, or preclinical safety? So then you go for a early phase 1, phase 2, and that's how that some of the resistant case, if you say lack of time disease model, poor predictive validity, and that the point is can I use the artificial intelligence, how much it will be successful? So we discuss about preclinical drug target. So if you look at the preclinical drug target, so people are looking at one of the pathways. So we always look at the pathway, that how it developed, pathophysiology. Is there any new pathway? So here, if you look at that, people are looking at metabotropic glutamate receptors. One of the compound has been used. Then orexin receptor, it is also involved. So another number compound people are working in a preclinical. But if you look at it, how many are phase 1 study? One thing is pathway working on dopamine is number compound. People are working at TAK 060. Then inotropic glutamate receptor, another number compound, B11104 has been used. Then, nicotinic symptoms, another compound, common one. So these are a pathway. If you look at that for a PG student, you need to follow it up. How many had completed phase 1? Is it stopped? And if it is stopped, you need to find out that why it is stopped. What is the reason? Is it a safety issue or some other issue? Then you look at the phase 3 study. How many are it is in a phase 3? Like you can say number of compounds is in a phase 3. So you look at the pathway 5-HT2, then glycine pathway. Then if you say muscarinic pathway, so the CARE XT has been already in a pipeline, a phase 3 trial. So you can just summarize that how many compound that is in a phase 1, phase 2, and phase 3. What I say critically, you look at that how many passed of phase 1 to phase 2, because phase 1 you only look at the maximum tolerated dose SPF, but when you go for a phase 2, definitely phase 2A and B, if it is cleared in phase 3, so you have in pipeline, the drug is coming to the market. So all clinical constellation of navigating the schizophrenia comorbid, because today you develop a drug, you test in a preclinical model, that is not enough, because we need that how about clinical situation practically. If you look at that, along with comorbid conditions, somebody is suffering from diabetes, hypertension, other comorbid CNS disease, and is it going to affect? And that's how that you always say that how you can have a quality of life with the ADR. ADR, it is tolerable, we can reduce. So structuring the system domain risks, when you look at all the psychiatric condition with the metabolic, physical, and behavioral aspect. So clinically, when you correlate with the animal behavior, we always look at all these points. So prevalence landscape, you can say the substances use disorder, depression. So this is also very important, because if the pathophysiology you identify that it is an anxiety disorder, is a depression or obsessive compulsive neurosis, accordingly you look at. So the diagnostic is very important. So clinician had already said about diagnostic and along with the pharmacogenomic. So metabolic cascade, that point is also there, because ultimately you look at the mortality and morbidity, how it triggered, antipsychotic, high risk of olanzapine, you say sedentary lifestyle. So in case of a metabolic syndrome, you have an obesity, hypertension. These are the practical points. You may discuss theoretically that you give a drug, but how about comorbid condition, diabetes too, diabetes mellitus and other. So that is why it is very important when you consider all this clinical intervention, that comorbid condition, it is also there, including substances abuse, how pharmacological control is there. So that's how the cognitive important point is, because many of the time in case of children, young children, they're going to school and college. You start with the therapy. So definitely if you say the attention, learning, memory, excessive, and these are points need to be evaluated during the preclinical studies and during the toxicity studies also, that you can say that how much it mimic the clinical situation, you can easily do it. Now, one of the peripheral node anxiety or OCS, or sleep disturbance. So you can look at that how many are anxiety disorder, obsessive compulsive. As you know, the preclinical studies, you always light and dark cycle. So sleep pattern, everything you look at, accordingly you can correlate it. So integrated master matrix should be there with all the symptomatology, then how all this SSRI or optimize the current system and which one is better. So that is why we say that all these guidelines, when you frame the guideline, how you prefer the first treatment, second treatment, and the duration of the treatment, and how you're going to monitor. So with stipulated time period, I just wanted to say that preclinical data is very important. And you can also think of doing an artificial intelligence, how much it mimic, and you can do the scanning system. We have all the techniques. So to conclude, you can say the schizophrenia is multifactorial and neuropsychiatric disorder as you listen to different speakers. So definitely preclinical data, it is important to correlate it, extrapolate the dose, and we need the treatment for resistant cases. We need the treatment with the comorbid condition. So with this, I just want to thank for an opportunity. These are some of the references, and Jai Hind. Thank you very much.
Thank you, sir, for that comprehensive overview. Finally, I invite Professor Dr. Rajesh Kumar Sir, Dean Research, Professor and Head of Department of Psychiatry at IGMS Patna, to provide the concluding remarks. He has over more than 70 peer-reviewed publications, a reputation as a distinguished assessor for NBEMS and NMC, and he is the recipient of IMA East Delhi Award. Sir, the floor is all yours. So your audio is muted.
Good evening. Am I audible?
Yes, sir.
Okay. Thank you so much for actually giving me this platform to conclude. Definitely since 4 p.m., I have been hearing all the learned speakers from Lalit to Vikas, and it's always treat to listen Vikas with such a vast knowledge and research experience. I think this is a very great endeavor by Dr. Lalit and his team. That's at least this is the second occasion where I think they have been collaborating with psychiatrists, and it has been a very, very wonderful and successful endeavor, I can say. Uh, I think I can only suggest that we can keep on changing the disorder, and we can discuss the various aspects of the neurobiology and the pharmacotherapy of OCD, bipolar in the subsequent months, and make it a periodic event. And this society of Association of Society of Pharmacologists of IGIMS, I can say, when Lalit approached me for the first time, really we feel very honored, and it's a part of collaboration that psychiatry is actually gaining lots of acceptance, and Vikas also told. And now coming to the individual presentations, like I also thank Dr. Harihar Dikshit sir for gracing the occasion, and he is the founder, president of the society. Like if I say about Nupur, I think she is our colleague, and definitely I have heard her presentation before also. All the presentations were very vivid, and excellent, I can say. Uh, but I think coming to the Dr. Pankaj presentation, definitely it was very exhaustive, but I think I was thoroughly engrossed into the various recent advancement, I can say, what actually he accumulated from the various sources. Like we are talking about precision medicine, and definitely it has been uh, I think it's not a reality, but definitely we can aspire to that in coming years and maybe decades, because when DSM-5 came into being in 2013, we had lots of hopes that the era of biomarker will commence very soon. But I think after that, NIMH came with RDoC criteria, and definitely we actually cannot do away with the paradigm of biopsychosocial. So Dr. Pankaj actually put a great effort in actually collating all the information, and definitely I would love if they can actually, we can have a WhatsApp society, and definitely where they can put up the presentations. So thank you, Dr. Pankaj, for very wonderful, very insightful presentation. Dr. Nupur, I think you helped us a lot, like clinicians and the budding clinicians, actually to have insight about how to choose antipsychotic. Definitely, we can say the history of schizophrenia has been very illustrious, but also enigmatic. Schizophrenia is one disorder where I can say it is one of the most complex neuropsychiatric disorders, and there has been multiple books, multiple journals, uh, actually ascribed to understanding the enigmatic and complex character of schizophrenia. Still, we are delving into the depth of the neurobiology of actually, brain is itself a very complex structure. When it comes to brain, I think either neurology or psychiatry, both actually came out of the brain. But definitely, we are dealing more about the softer aspect of the brain, like what we say neurotransmitters, and neurology, they are actually discussing more about the harder, like the lobes and the various structures. But we can say ki where I think if we can have also collaboration with a neurologist in this forum, so actually it will add variety and also meaningful heterogeneity to this discussion. So this is one of my suggestions that we can move on from various disorder, and also we can actually include, besides pharmacologists, psychiatrists, we can also include neurologists into this. And last but not the least, I think Vikas. I think what I can say about Vikas is a world famed pharmacologist and researcher. And definitely, whenever he comes or I listen online, offline, I learn a lot. So I once again thank Department of Pharmacology, led by Dr. Harihar Dikshit, and you have a brilliant team, Shajid and Sukalyan. Actually, they add value to your department, and please keep on this good work. Uh, that we actually in this IGMS, where actually we can have such scientific and research platform where we can share our views, and definitely we can disseminate the information and serve the humanity and the society. So last but not the least, I think the two hours listening to all the four speakers, it was a treat. And I will not add much because definitely you people have given such a exhaustive reviews about that, and definitely I was just thinking all these presentations must be shared so that I can share among our residents and senior residents so that they can benefit. So once again, Dr. Lee, thanks for including me, and I wish you good success in future. And I wish that you have great luminaries of a speaker in the future also. Thank you so much. Hello.
Thank you, sir, for your encouraging closing thoughts. As we conclude, I would like to extend a heartfelt vote of thanks to our speakers for their time and invaluable insights today. Also to the organizing committee and our collaborators, and all the attendees for making this session a success. Thank you so much. Have a great evening.